Well, welcome to our School-Based Health Center Quality Improvement webinar. Kevin, would you care to review the usual administrative matters?
Sure. So thank you for joining us. Usually we were on a little bit earlier, but we had the wrong route, virtually speaking. So if you can hear us, your audio is good. Jan, if you have access to your microphone and you'd like to participate in the discussion that way, that'd be great. I understand sometimes it doesn't work. If you're able to and you have a camera, you can enable your camera now. I do have those enabled. It's in the top middle. It looks sort of like a camera icon. Just click on that and that should get you on camera. Otherwise, if you're on the line on telephone, *6 is your mute and unmute. If you want to receive CMEs and CEUs, you just need to announce your name, where you're from, and Jan, we have you down as being from UNM College of Nursing. And the session is being recorded and will be available on our videos page on our website, envision.nm.org, in the next 48 hours or so. And pass it on to you, Dan.
Also, this slide contains further information about our accreditation with regard to CMEs, and also disclosure that I have no personal interest that would be of conflict with anything that we're doing today. And I know that's the case for Kevin too. I thank Kevin for being here. As usual, he's of tremendous technical support and also provides me and other presenters with a sense of continuity as we go from conference to conference here at Envision, New Mexico. I fondly refer to our room as Studio Envision. But anytime you're in the downtown Albuquerque area when we're going to be having a webinar or a case conference, by all means, you're welcome to join us here as well. Jan, are you able to see us here in the conference room at Envision?
And she says yes, and she can also see the slides and hear you.
Great. Terrific. At any point, especially Jan, since you're the one and only out there in cyberspace witnessing and watching this conference, you're really having an opportunity for us to have a conversation about today's topic, effective school-based health center approaches to enhance student mental health. And Jan, am I of the correct understanding that this is the first time you've connected with us, or am I recognizing your name because you've connected with one of our webinars or case conferences in the past? Great. Okay. Terrific. So as you probably know, school-based health centers are clinics in schools. Here at the Department of Pediatrics at University of New Mexico School of Medicine, we now house the UNM School-Based Health Center program, which operates 6 school-based health centers. And in half of those, I provide psychiatric services when I'm not here at Envision, New Mexico, and I also provide psychiatric services in the pediatric clinic in 3ACC 1 day a week. We have you on our roll call, so let's move on to talk about today's goal. Our aim is to provide efficacious behavioral health treatment approaches to students. That's our purpose, our goal, our aim. And in order to do so, we're going to identify empirically supported behavioral health treatment approaches for students, some of which I'll be elaborating on today, some of which will be elaborated on in future sessions. We're going to describe effective behavioral health treatment modalities for youth, and we're going to appreciate how multimodal behavioral health treatment usually is most effective. So as we look at what mental health or behavioral health treatment components are integrated in school-based health care, and that particularly refers to our school-based health centers. We have psychotherapy to offer at all of our sites, some more than others, and especially when taken in consideration with school-based therapists who are occupying the space with us in the schools. Psychopharmacotherapy when indicated, and school-based health centers do a especially wonderful job of integrating care involving provider collaboration, both during student visits and in team conferences. Well, let's take a look at the psychotherapy part of this. And then we'll look at psychopharmacotherapy briefly, because that's going to be a whole topic for us to consider in future webinars, but there's a part of it that I'm going to talk about that really relates to the multimodal behavioral health piece. And then we'll talk some more about the care integration. So when we look at psychotherapeutic intervention, it really begins with the screening and assessment that providers typically do in school-based health centers, which creates therapeutic opportunities. And you'll see here is some specific information that pertains to our standard practices in school-based health centers. For example, when students are screened using a student health questionnaire or SHQ that's reviewed and interpreted with a provider, if that shows positive findings of risk for anxiety and or depression, an assessment instrument will be used, as talked about in these webinars previously. During the process of reviewing the findings in the screen and in the assessment instruments, there are many therapeutic opportunities because the student experiences their concerns heard. An opportunity results to talk about those concerns, which often leads to motivational interviewing opportunities, and to have psychoeducational interventions. Now, we've talked about this scheme in the webinar previously, and I was just referring to opportunities resulting when there's screening and opportunities resulting when there's assessment. And these are areas where our healthcare providers play a vital role. It's not only the behavioral health providers that are doing this kind of initial psychotherapeutic intervention. Well, as we look further into our psychotherapeutic approaches, we have modalities of individual, family, and group. And we're going to talk more about those approaches that pertain to individual and can also be further carried out in family and group settings. I just mentioned in the earlier discussion about motivational interviewing. Cognitive behavioral therapy and interpersonal therapy have perhaps the most empirical support. We all end up doing psychoeducational interventions at some point in our work, and it ends up being a feature in most everything listed here, as is therapeutic support, which alone is referred to as supportive psychotherapy. And there are other psychotherapies as well, such as solution-focused therapy, which Dr. Avi Kreichman gave a webinar with a behavioral telehealth program through UNM Department of Psychiatry's CBH, that's the Community Rural Behavioral Health Group. Okay? And that was on March 5th. If you have an opportunity with further interest, you want to find out more about solution-focused therapy, I'd recommend contacting CBH, the Community and Rural Behavioral Health Group with the Department of Psychiatry, to see if there's a recording of that webinar, and also watch for Dr. Kreitzman's webinars in the future. He's very knowledgeable and very reputable source of information and good presentations. Lastly, I want to mention modularized or common elements approach that we'll be talking about with reference to an upcoming webinar. So having laid the foundation of what we're going to do today, let's talk about motivational interviewing. We have motivational interviewing at Envision. In our telehealth programs, we feature motivational interviewing both in open mic, which will resume on Thursday, March 20th during the noon hour, and I think it's twice a month thereafter. And ComTC, our Children's Overweight Medical Management teleconferencing, which also is semi-monthly, the first and third Friday of the month from noon to 1:30, in which we frequently talk about motivational interviewing. Well, Jeannie Dalen, a clinical psychologist, will resume open mic on the Thursday, March 20th noon hour, and she's also going to be giving a specific presentation in ComTC on Friday, March 21st on motivational interviewing for behavioral health change in adolescent populations. And during our recent ComTC installments, going back to last month, Dr. Dalen and I were talking about how motivational interviewing gives us an approach wherein we really apply that notion mentioned earlier of our psychotherapeutic intervention, beginning with our assessments, and how during the course of talking about students' concerns and performing psychoeducational interventions, we have great opportunities to talk about how ready youth are to make changes and what kind of changes they can make. So I hope you'll consider joining open mic or ComTC to hear and discuss with Dr. Jeannie Dalen later this month. The next psychotherapeutic approach I mentioned was CBT, or as it's known as, cognitive behavioral therapy, which is based on the tenet that thoughts are major determinants of feelings and behaviors, after the work of Dr. Aaron Beck and others going back to the 1970s. Used both with and without medication, CBT has become the most popular and commonly used psychotherapy for treatment of depressive and anxiety disorders. It has an evidence-based efficacy that has been found to be longer lasting than psychotropic medication alone for some psychiatric disorders, especially those in the domains of anxiety and depressive disorders. And previously, CBT began as a modality to use with adults. It's been used more and more with adolescents as well. And the main intervention strategies are the following three components: cognitive restructuring, exposure response prevention, which is behavioral, and the adjunctive techniques, which support the above. It's the cognitive structuring that I'm going to say the most about today, because it really brings to light the effectiveness of the tenets upon which CBT is based. We can think of a triangle at which there are the apices of cognitions, behaviors, and feelings. With cognitive restructuring, there is an identification of, a challenging of, and a replacement of faulty, distorted beliefs that can cause depression and anxiety, and that these are replaced with more positive and logical cognitions. Cognitive restructuring addresses automatic thoughts, which by nature are negative, illogical, self-defeating, distorted, preconscious, and habitual. So let's take a look at what that means. One, habitually or automatically, without full awareness, that is, if any awareness at all, it's below one's conscious awareness, has negative, illogical, self-defeating, and distorted thoughts that forms the basis of one's depression and or anxiety, if you will, so that one can have what has been referred to as irrational fears, because one is fearful of that which goes upon rational likelihood as an event to occur in one's environment, and it causes them tremendous anxiety. Or one is self-defeating in their thinking. Classical example, self-talk about how one is no good, overly critical of oneself, tend to overly read negative self-defeating messages in everyday events. Automatic thoughts that get in the way of one's healthy functioning and well-being. And then there's the exposure response prevention, which is behavioral. Can be applied to excessive, repetitive, and avoidant behaviors. And one of the beauties of CBT is how if one can behaviorally make a change, rather than approaching it only cognitively, but if one can move themselves toward a feared object, for some people it could be getting out and about and going on with their day despite how depressed, anxious, and lousy they feel. The better their mood is going to be, the more positive their feelings are and their thoughts. And then there are the adjunctive techniques such as relaxation that supports the behavioral and cognitive therapeutic aspects of CBT. Next, interpersonal therapy, or IPT, is the other therapy that I'm going to say the most about today, because it's one of them that has the most evidence basis, and I'd have to say that it's more coincidental that IPT and CBT approaches are the ones that I've come to use the most in kind of a combination of a little bit of each and a little bit of that as needed. But actually, interpersonal therapy is a manual-based therapy that when one does the entire approach, it's divided into a number of sessions with various focuses, having to do with a tenet wherein depression occurs within an interpersonal matrix. And IPT for adults has been developed, known as IPTA, and adapted from IPT, which is a well-established, efficacious, brief structured treatment for adult depression. It's so structured that it is laid out in a manual. And some therapists do extremely well with a manual that instructs one with how to proceed, almost a session by session, or in the case of IPT, it may be 12 sessions stating the objective of groups of threes, if you will. Now, IPTA aims to resolve interpersonal stress associated with adolescent depression, which is a really important feature of IPTA. I'm going to jump to the second point about how it's a developmentally appropriate treatment because adolescence is a time of role changes, conflicts with parents and family, and emotional investment in peer relationships. And often what this means for a number of adolescents is that there can be various degrees of upheaval of what life used to be like and known to be in an adolescent's previous experience. IPTA takes an interpersonal inventory of important relationships to determine appropriate treatment targets, such as losses and grief, interpersonal disputes, alluded to earlier, role transitions, and interpersonal skills deficits. And literally the first session or two, even going into a third, are focusing on the interpersonal inventory of important relationships. And in comparing IPT and CBT, I think it's really worthwhile to look at how, again, these have the most empirical support. There are some similarities in the techniques, and there also are some differences. The similarities include encouragement to maintain normal activities, alluded to earlier when talking about CBT. If one goes about their life and has positive behaviors and a productive day, they're going to feel better and have more positive thoughts, according to CBT. With IPT, there's going to be fulfillment through interpersonal interaction in important relationships. Both involve problem solving and skill building. However, there are some different constructs. IPT tends to look from the outside in at the individual, whereas CBT tends to look at inner experience and how it relates to the interpersonal. Now, I want to comment about that briefly because that second point about CBT would have really surprised me during my early studies of CBT, which actually would go back to my psychiatry residency, because CBT was looked at back then as much in contrast to more traditional psychodynamic and even preceding psychoanalytic theories, which tended to be very in-depth and very focused on the inner experience that one has. But CBT really does look at inner experience as well, but it looks at it with its eye on behaviors at the same time. Lastly, on IPT and CBT, psychoeducation is really important to both. As mentioned earlier, psychoeducation is something that can be done with all of these approaches, and it ends up becoming an important piece. So again, psychoeducational interventions are such an important part of everything we do, whether it's the review and interpretation of screening, assessment, approaching and proceeding with psychopharmacotherapy, as with patients earlier today, psychosocial therapies, and so forth. It involves education about assessment, etiology, symptoms, and other diagnostic features, course, and treatment. It's very useful during the informed consent process, whether it be about the particulars of medication treatment or the overall therapeutic process itself. And it does have therapeutic benefits in and of itself, as psychoeducational interventions can help reduce symptoms because it can help the individual make sense of their symptoms and can really support them in adhering to their treatment plans. What's similar about supportive psychotherapy is how commonly we provide therapeutic support in our interactions with our patients, as we often are providing them with psychoeducational benefits as well. Therapeutic support refers to the empathic, active listening and other support that we end up providing to our patients, often instinctually. But it really is an important component of all treatment interventions. Again, as its own modality, it's known as supportive psychotherapy. It does support current assessment and treatment plan development efforts. It helps maintain understanding, assist with problem solving, and restore and maintain hope for our patients. And lastly, modularized or common elements approach to therapy is becoming very common. You know, earlier I mentioned how I'm often doing a little bit of this and a little bit of that during the psychotherapeutic interventions that I perform with my patients, many of whom are students. Well, this has been further developed in this notion of pieces of different approaches has really been assembled into what's become known as modularized or common elements approach to psychotherapy. And I'd like to invite you later this month, the last day of the month, which will be Monday, March 31st, an hour earlier than this one, from 2 to 3 p.m., for Dr. Sharon Stephen, a clinical psychologist at the Center for School Mental Health at the University of Maryland School of Medicine in Baltimore, who will be presenting a school-based health center quality improvement webinar in behavioral health entitled Using the Common Elements of Evidence-Based Practice to Improve School Behavioral Health. I can't recommend this presentation and the work of Dr. Sharon Stephen enough, and I hope you'll be joining us that afternoon. We're very excited about Sharon's enthusiastic participation in this webinar. She's so highly regarded, and many of us know her from our work in this field. I'm also going to mention the modalities of, I see, please, I missed your comment. I saw there was a pop-up there, Jan.
Sounds good. I will attend.
Excellent. I hope you will. If I lead you wrong on this one, Jan, you let me know. I think it will be really worth your while. I'm confident that it will be. So I'm also going to mention family and parent involvement because I think that this is such an important, pivotal therapeutic opportunity that often is underutilized in school-based health centers, which I think is really a misfortune. I think this is where school-based health centers sometimes can be doing more to help students because we naturally develop opportunities for involving parents and family in students' behavioral health treatment. And one such example is during the informed consent process. It naturally has psychoeducational and supportive components, and family therapy can complement individual treatment. Now there's, I think, a tradition in school-based healthcare that sometimes works against family and parent involvement, and that has to do with the tradition of providing confidential services. I entirely respect those. I've provided some of those services myself, and at the same time, I think it's important that we keep our eyes open to the potential for family and parent involvement in behavioral health care. Now, the second main component to effective school-based behavioral health care includes psychopharmacotherapy when indicated. And we're going to have a couple upcoming school-based health center quality improvement behavioral health webinars devoted to this topic. Psychopharmacotherapy for student depression and anxiety. And it will be divided into part one, which will have to do with the requirements and guidelines, largely how to approach psychopharmacotherapy and make psychotropic medication prescribing an important therapeutic opportunity for students, as well as part two, which will be selections, largely about the psychotropic medications themselves by groups, and integrating the psychopharmacotherapy into the overall behavioral health treatment plan. So please watch for future Envision New Mexico telehealth session email announcements, and you'll also see postings on our envisionnewmexico.org calendar, as there is a posting for today's webinar. But a couple pieces that I want to extract from those offerings to review today have to do with the combination of psychopharmacotherapy along with psychotherapy, which I abbreviate this way, and the psychopharmacotherapy, which is abbreviated this way. Because there's some important guidelines and empirical support for this that are largely from my child psychiatry professional organization, the American Academy of Child and Adolescent Psychiatry, known as ACAP, AACAP. By the way, their website is very effective. In that website, you'll find practice parameters as well as policy statements. The American Academy of Child and Adolescent Psychiatry recommends starting treatment of depression and anxiety with psychotherapy alone, especially for younger children. And everything else that's stated in this slide has to do with how, if we're going to be prescribing medication, we should be providing therapy as well. Providing medication alone just doesn't cut it. It doesn't provide a comprehensive biopsychosocial oriented treatment for youth. Now, more and more, we're finding combined psychotherapy and psychopharmacotherapy as a first-line treatment, and an effective one for adolescent depression and anxiety, especially when severe. And also, the realities are there's a lot of third-party payer pressure to be prescribing antidepressant medication to depressed youth, along with providing the psychotherapy, and likewise for youth struggling with anxiety. And the policy statement at the end here is saying basically what was said earlier about needing to make sure therapy is being provided to those who are also receiving a prescription. Now, there is an evidence basis for the combination of psychopharmacotherapy with psychotherapy. There's a multi-center treatment study referred to as TADS, the Treatment for Adolescents with Depression Study, published in JAMA several years ago, which basically found that the combination of an SSRI, in this case fluoxetine, which was originally known as Prozac, along with cognitive behavioral therapy for adolescents, provided greater efficacy than either an SSRI or cognitive therapy alone during the acute and continuation phases of treatment. And I'm emphasizing that because the same study has been used to make the point that for long-term maintenance of improvement and recovery from depression, there's been a finding in the TAD study as well that cognitive behavioral therapy alone was at least as effective. Both are true. But it's in that acute and continuation phases of treatment that are so crucial. And when we look at how, for the treatment of depression, for example, there can be suicidal ideations, perhaps death wishes, and other severe depressive symptoms, including both in the acute phase of treatment, is very important. Later, several months out, cognitive behavioral therapy at that point is at least as efficacious as the combination. So we're finding definite advantages to multimodal treatment. The combination of therapies enhances efficacy in ways that are consistent with the etiologic biopsychosocial model, which includes addressing comorbidity, an opportunity for efficacious integrated care, and that psychotropic medication plus psychotherapy usually is superior to either alone for the treatment of depression, anxiety, and coexisting conditions. And when this becomes a multimodal treatment plan that is comprehensive, it includes the aspect we've been talking about today. With psychotherapy, psychopharmacotherapy, when indicated, we can add in healthcare maintenance, including complete physical exam, looking at lifestyle considerations such as nutrition, activity, substance use, whether somebody's using tobacco or even occasional alcohol or drug use, whether that's a healthy lifestyle for the individual, especially with regard to behavioral and mental health. And if needed and available, case management. Now, I mentioned earlier the integration of care, and school-based health centers integrate care to provide multimodal treatment as well, if not better, than any other treatment venue that providers work in, because we're able to really work along the principles of comprehensive multimodal treatment involving multidisciplinary care, integrating the care by involving provider collaboration during student visits and team conferences, as said at the outset. Continuous collaboration, continuing to discuss the student in treatment team, formalizing our treatment conference so that we can be sure to continue discussing the care of students, and applying best practices in our programs to prescribing and monitoring procedures. So we welcome integrators of care to our school-based health centers, and we recommend beginning our collaboration early. And having said all of that, Jan, I'd want to ask if you have any questions, comments, concerns, protests, beliefs, other thoughts that you'd care to share.
She has a question. Are school-based health centers in elementary, junior high, and high schools?
Yes, they are, Jan. They have tended in many programs to be more prevalent in high school and middle schools. In our 6-site school-based health center program, half of our sites, 3 of them, are in middle schools, 2 of them are in high schools, and 1 of them is in an elementary school. Since you're our one participant, is there anything else that you would want to ask or comment about?
Her response, I am in clinical practice with Early Head Start program. I wonder if school-based health centers would be appropriate with children as young as our population.
So you're talking about preschoolers, I gather.
Yes, 0 to 3 years.
Certainly may be. We've seen a school-based health center develop at the Peanut Butter and Jelly Therapeutic Preschool. I think of that age as being more in the range of 3 to 5, and it sure has been helpful there. You might want to consult with Peanut Butter and Jelly's Therapeutic Preschool to find out if they still have a school-based health center and what ages they're working with.
She says she is familiar with that program.
Great, great. Well, Jan, I thank you for joining us this afternoon. We'll look forward to you joining us in the future and including those webinars that have been mentioned for motivational interviewing, and certainly the common elements approach to behavioral health in schools. I would also want to mention to you that if you know of any school-based health center providers who are looking for case consultation, discussion, and the opportunity to develop a learning collaborative, we have a school-based health center integrated behavioral health provider case conference forum coming up next Wednesday afternoon, a week from tomorrow, from 3 to 4 p.m. Of course, you'd be welcome to join us there as well. And also for case-by-case, provider-to-provider consultation, I continue to be available approximately 4 hours a week. The 2 to 3 o'clock hour tends to work best for me, Monday, Tuesday, Wednesday, and Friday, but we can be flexible in order to meet the needs of our providers at other afternoon times. So there are some references, and do keep in mind that we continue to have resources available at the Envision New Mexico website, including our calendar postings for upcoming conferences, and as always, the standards and benchmarks for school-based health centers from the Office of School and Adolescent Health are posted at the OSA website and at the New Mexico Assembly for School-Based Healthcare. So Jan, we know you're out there, so you are counted today, and I want to thank Kevin again for all of his technical support. Thanks for being here again, Kevin, and helping out in so many ways. And I'll continue to look forward to next time. Thank you, Jan.